One day, our patient Tony is walking in the ward. Suddenly, he collapsed. What should we do? Hello everyone, it is registered nurse Anthony. Today, we are going through the CPR and BLS for adults. Before we put our hands on the chest, we have to figure out what phases of the resuscitation is. The first one is the electrical phase. It is the first 4 to 5 minutes after sudden cardiac arrest. Immediate defibrillation is required. We have to prepare the defibrillators quickly during the excellent chest compression. The second one is the hemodynamic phase. It may span for 4 to 10 minutes after the sudden cardiac arrest. In this situation, excellent CPR can improve the cerebral and coronary perfusion. Just like the first phase, immediate defibrillation is required. The third one is metabolic phase. It begins from about 10 minutes of pulselessness. The patients are rarely survive from this. We have to focus on compression over ventilation in the early stage. It is because after the collapse, lungs have enough oxygen and blood is oxygenated. Excellent chest compression can improve the O2 delivery to tissues. It is why the CAB protocol is used. There's some additional situation if the cardiac arrest is due to prior hypoxia. Oxygen reserves may be depleted. Standard CPR with ventilations can make sure the O2 delivery to tissues. As we said before, excellent CPR can improve the cerebral and coronary perfusion. It can enhance the return of spontaneous circulation. It is therefore, excellent CPR is more important than any advanced procedures. So, let's approach Tony. First, we have to evaluate the responsiveness of Tony and call for help to start the EMS and let them bring the defibrillator here. Then, we're gonna assess the breathing and pulse of Tony, but remember that the process should not more than 10 seconds. If Tony have normal breathing and pulse, it's all good. Just keep monitoring until the emergency responders arrive. If Tony don't get a normal breathing, but pulse presents, we have to provide rescue breathing. It is one breath every 5 to 6 seconds. If Tony get no breathing or gasping and no pulse, we have to start the CPR immediately. So let's jump into the C. Remember, push hard and fast on the center of the chest. First, we have to let the patient lie on a hard surface, and our position is placing the heel of one hand on the center of the chest and below the sternum, and then place the heel of the other hand on top of the first. We're gonna align our chest directly above our hands, and the chest compression rate should be 100 to 120 per minute. If you push it too fast, it will impair the venous return. And remember, the diff should be more than or equal to 5 cm, but avoid more than 6 cm. We have to make sure complete chest recoil after each downstroke. It can enhance the negative intrathoracic pressure, then increase the venous return and coronary perfusion. We will give 2 breaths after every 30 compressions. If there's more than one rescuer, we can change the chest compression giver every 2 minutes. It is very significant that we have to decrease the interruptions of chest compression. For example, we can change our chest compression givers during the rhythm track, and we can perform pulse check and rhythm analysis without compression, only performed every 2 minutes. After any pause in compression, it may take more than 1 minute of consistently high quality compression to regain adequate perfusion pressure if Tony is found on the streets. And there's only one vascular. The vascular can choose not to perform mouth-to-mouth ventilation and only perform the excellent chest compression until the AED is ready to defibrillate or the EMS take over or the patient wakes up. We can take advantage of some devices to monitor the quality of chest compression. For example, some mechanical devices, it can provide real-time feedback of rate and depth of the chest compression and of the chest recoil. Furthermore, we can use the end-tidal carbon dioxide measurements if it is less or equal to 10 mm mercury. It may represent to poor outcomes. If it is more than 20 mm mercury, it may represent to higher rates of ROSC. Determine the presence of ROSC by these devices can decrease the interruptions by skip the pulse checks. Invasive arterial pressure monitoring can be considered as well. We're gonna measure the diastolic blood pressure. The arterial BP monitoring is not recommended in early resuscitation. The exception is that there's existing arterial device or adequate personnel to insert the catheter. The catheter insertion should be done during uninterrupted chest compression. So here it comes with the A, airway. We have to remove the obstruction or secretions from the airway, and we have to perform head-tail chain lifts, and we can insert the oropharyngeal airway for airway patency. Here it comes with the B, breathing. Ventilation becomes more critical as the pulselessness continues. We may prepare the bed mask device for ventilation and administer supplementary oxygen. The flow rates from 10 to 12 liters per minute. We have to make sure the airtight seal between the mask and face, and we will keep 30 compressions and 2 breaths before the advanced airway, and we have to stop compression briefly for patients without an advanced airway to let them ventilate. We have to give adequate tidal volume. It is about 500 to 600 ml or 6 to 7 ml per kg. But for the patients with advanced airway, we have to make sure 6 to 8 asynchronous ventilation per minute and deliver air more than 1 second, and only until the chest starts to rise. We don't want excessive ventilation because the positive pressure ventilation will raise the intrathoracic pressure, decrease the venous return, decrease pulmonary perfusion, decrease the cardiac output, and cerebral and coronary perfusion pressures. It will decrease the survival. Here it comes with the D, defibrillation. We have to perform the rhythm assessment every 2 minutes. If there's shockable rhythm, like VF or a pulseless VT, we can give 1 shock. For the defibrillator pad, it can proceed on the anterior and lateral. If the VF or VT be refractory to multiple attempts, we can place it to the anterior and posterior position. In some situations, we can add additional sets of AP pads too. If it is the biphasic one, we will turn it to 200 joule. If it is the monophasic one, we will turn it to 360 joule. It is the maximum available energy for the antidote. It can decrease the interruptions and increase the probability of successful defibrillation. After the defibrillation, we have to resume the CPR immediately to increase the post-defibrillation perfusion. We only check the pulse and rhythm 2 minutes after the defibrillation because there's delay between an efficient myocardial contraction and restoration of an organized electrical rhythm. Alright, we've been going through the CABD completely. Let's talk about another C. Complications of CPR. I'm gonna say the benefit of excellent CPR is far more than the complications. The potential complications including the rim and sternum fractures, pneumothorax, hemothorax, cardiac and pulmonary contusions, or intra-abdominal trauma. If you want to get the notes of the CPR we've been going through today, you can click the link in the description. It is totally free. So I will see you in the next duty. Bye bye.